What we have found is that there has been improved communication with CMHTs. The care coordinator, the CPH's colleagues are very supportive. I think there's been a big sea change regarding how the position has been viewed. I think initially from chatting to the two secondees that they felt they were always chasing the colleagues for service users to suggest or for problems regarding their client's physical health. I think after perhaps 1, 2, 3 months further down the line is that that's completely different. They've been approached by their colleagues to say, oh, I've got a concern, I've got a problem, which is great to see. You can see how the education building in with that physical health focus really makes a difference. Primary care, they were pleased. It went really well. There's not really much more to say apart from that they felt that care started to become coordinated. It was the first time for some of them they felt they really had contact with the CMHT. I think one of them said it was like a light bulb moment or eureka moment, which I know is a bit of a cliche, but that's what came across, because they didn't understand or realise how much interaction a care coordinator would have with their clients. And then when they found out, it was like a new resource open to them, which I think is quite a learning point. In the initial work, as Michelle mentioned, the discovery work, is that not in every case did service users think that they were discussing physical health with their care coordinator. However, after about 6 or 7 months, we went back to speak to them again. In every case, they felt they discussed physical health with their care coordinator. And there's also a big increase in the number of care coordinators who discuss lifestyle services and appropriate referral. We're not saying they made referrals, but they discussed when were the right times of perhaps referring, were they motivated. And back to the CBD risk data I chatted before about the Q risk and how we looked initially about using that as a stratification tool for discussing clients. And as you can see here in practice 2, in 90% of cases there was data missing to be able to work out the Q risk score accurately enough. Which I think is quite a worrying fact that the access to primary care or the investigations recorded and performed was very poor. As you can see over time, in the purple ones, there's been a massive increase in that, and I think that's because we've generated that access and that continued message through the community physical health coordinator has allowed people to get into practice. And that leads into the next slide, which is the outcomes of these MDT meetings. I think as Michelle mentioned about the evaluation, we were quite key that we had to collect some sort of process and outcome measures. And here, I know it's quite small and quite hard to read, what you can see is the majority of actions, 43 out of 163, have all been focused around disease reviews, which is what we're after, is what we're trying to find. And again, primary physical healthcare assessments, that's 32 out of 163. So we find that these were the main actions coming out of these meetings, and it is that coordinated approach that's helped that. I think what we have found is that asking someone to attend, asking a service user to come to a practice initially doesn't always work. Sending a letter out doesn't always work. That coordinated approach between the care coordinator, the assistant practitioner, the GP and practice nurse has much more success in getting them in through the front door. This bottom bit here, again, I think the mental health trust are quite concerned that holding these meetings and having discussions, there'd be a big pushback from the GPs to say, it's not our responsibility, it's your responsibility. We're not performing the actions, it'll be CMHT. But in fact, we found that there's a really good, even split between joint actions with the practice and the CMHT, CMHT actions, consultant actions, and primary care actions, and it's a really good third divide. And these are some outcomes from the service user. It says perspective, but they're more case studies really. And I won't go through these in much detail, but you can see the left of this one here is about somebody having CKD picked up who previously neither the care coordinator or the GP had any idea that abnormal blood tests, and due to the fact of this process, we've picked up and then referred into the appropriate service. And there's one more here which is about a gentleman who found a lump in his testicle and how a system which may have fallen down due to the fact of a female doctor, but through the dialogue and the multidisciplinary working, that was addressed and it was assessed in an appropriate manner. And this is an actual story written by a service user from one of the care coordinators. And this person who wrote this quite liked to write poetry, and that was what he liked to do in his pastime. And he wrote this really nice story about how working with his care coordinator and the community physical health coordinator made a massive difference to his care and how different sides were all combined. This was done at the end of the project, as post-project again. And so this is a questionnaire that was sent out to survey to all of the care coordinators attached to North West CMHT, who the physical health workers were working with. And you can see everybody agreed, or strongly agreed, that physical health care was important to their role as a care coordinator. And that's quite a divide, and so that's quite a move. And I haven't got the stats up there, but there's a really nice quote from one of the physical health coordinators that talks about previously not every care coordinator really thought that physical health was part of their role, but they now thought, and now seen that progression to say that it actually was. The next one here is about the actual role itself. Was having a positive impact on their service user care? And again, fantastic results. Yes, agreed, strongly agree. Access to primary care for clients. You can see again, the majority agreed, so 8 out of the 13, 8 out of the 12, 14, I count. 8 out of the 14 agreed. One person disagreed, but that was a different issue altogether. However, it shows that again, we are trying to break down the access problem. And the final one is the impact on patient care. You can see again, it seems to be working very, very well. And this is just some more qualitative stuff, which is just as we've gone through before previously. Like this GP mentioned here, it's holistic care. I think what we have found is that yes, our meetings and MDTs are focused on physical health care. However, what you have found is that having that focus on physical health means that other discussions around holistic social care get brought into that. I think having an open forum for discussion would probably be a nightmare to try and manage due to the issues regarding referrals, and it'd be a slanging match on either side regarding access into certain systems. So having that focus has taken all that kind of noise away from that. And back to the Schizophrenia Commission. Yeah, so what I tried to do is see what we're trying to target about this work. Well, the first one, I think we've managed to do that quite well. I think we have managed to explain the responsibility and having clear focus of who's actually performing what and who's going to carry that through. The second one, yes, again, we are providing more training around physical health, and systematically that will be done and delivered on a basis throughout the trust at CMHTs. Third one, I put a question mark because although I'd like to say that yes we have, I think we've gone a little bit of the way but not the whole way. And on the back of the work is, back what we've done is, medication was an issue, and so we have launched another piece of work with the trust around a medication helper which links up the service user and how having them responsible for those transitions of care between primary and secondary. Better training for GPs, I'd love to say we've done that, but I'm afraid we haven't. I think in the commission it looks certainly Royal Colleges. What we have found is probably anecdotally, the interactions with mental health employees has improved the knowledge of our service users and of mental health and an awareness. So work cessation, again, a question mark. I would to say that was happening, and I think it probably is, but I couldn't guarantee and say that it was. Motivation, that's the biggest problem we have. So how do we actively motivate service users? And I think that's something which, again, it's a coordinated message. It's health promotional work. It's utilising what we have, but it's always going to be difficult. And finally, I've put a tick here because I think we have utilised services like the health trainers. There's no capacity in the service that we were given to try and have a dedicated weight management class for targeted service users. But I think utilising what we have, we've kind of addressed that. And that's pretty much it, to be honest. It's kind of over to you to see how that's different to your services, how we could use that in your practice, is the way of working, really.